Well, I think, one of the biggest trends in RA management really is based off the really changing guidelines that we've seen in the 2012 ACR guidelines, which begin to call for earlier and more aggressive treatment of new patients, as well as more aggressive treatment of existing patients who are not doing well on existing therapy. So, the ability to move from, DMARDs alone to DMARD and a biologic combination earlier in aggressive disease, as well as, not playing these, multiple TNF progression, but being willing to go to a different MOA after the first, TNF failure, for instance. So a lot of it is about more aggressive escalation of therapy and more aggressive treatment early on in the disease. And now I think one other newer trend is what's going to be the impact of the new JAK inhibitor, tofacitinib, on treatment paradigms now that we have the first, non-traditional, DMARD oral agent. As you might expect, the major cost concern in treatment management of RA are the drug and drug-associated costs. If you look at specialty pharmacy across a wide spectrum of diseases and disease areas, RA as an autoimmune disorder is always in the top three. It's always RA, MS, and cancer, with RA often being the number one in that. So, the real cost driver is drug cost. So plans are looking at a way not to necessarily minimize drug costs, but to optimize value for drug costs. You want to get the right drug to the right patient the first time, so you're not having to switch drugs, because there is a cost to switching versus maintaining therapy, and that cost may be both economic and clinical. So it's really about effectively managing the drug costs, getting the right agents and the right treatments, and doing it right the first time.